Welcome everyone. Today, we're peering into a critical aspect often overshadowed by the urgent rhythm of beeping monitors and life-saving procedures, gastrointestinal failure, an often neglected part of multi-organ dysfunction in ICU. Stay tuned as we uncover the pivotal role nutrition plays in patient recovery, the intricate dance between feeding the body and healing the gut, and the innovative strategies clinicians employ to fight malnutrition. Get ready to be infused with knowledge. Let's dive in. In critical care, addressing nutritional needs is key to combat malnutrition and its serious health consequences. Managing acute underfeeding, often a nursing responsibility, is challenging due to its delayed impact. Gastrointestinal (GI) failure in ICU patients is not as closely monitored as other organ failures, lacking standardized protocols and often excluded from multi-organ failure scores like SOFA. The GI tract, crucial for defense and high in energy demands, is especially at risk during shock. ICU treatments, including pre-surgery fasting, exacerbate GI failure. Although acute gastrointestinal injury, AGI, has a grading system, now evolved into the gastrointestinal dysfunction score, GIDS, identifying reliable biomarkers for GI function remains a challenge. Systematic clinical assessment of GI symptoms is essential as their increase correlates with higher mortality, underscoring the importance of enhanced GI issue recognition and management in ICU settings. To assess the gastrointestinal function and nutritional status of ICU patients effectively, the following steps and considerations are outlined. Nutrition risk screening, NRS. Conduct within the first 48 hours of admission. An NRS score of 5 or more is associated with increased mortality. Enteral feeding tolerance. Enteral feeding tolerance is the gold standard for monitoring GI function. Assess the gut's ability to meet nutritional needs through patient monitoring. Gastrointestinal dysfunction score, GIDS, includes the absence of oral food intake as a marker of dysfunction. Food intolerance identified by clinical examination at least twice daily. Clinical examination for food intolerance. Look for signs like vomiting, regurgitation, abdominal distension, and abnormal bowel sounds. Check for abdominal pain, stool presence, absence, stoma flow, severe diarrhea, increased intra-abdominal pressure, IAP, and GI bleeding. Gastric residual volume, GROV, measure by gastric tube suction or with a drainage bag and observe for a set period. Ultrasound can evaluate gastric overfilling, free fluid, digestive loop distension, and tube placement. High GROV indicates a higher risk of vomiting and may reduce nutrition delivery. Management of high gastric residuals. Use prokinetic drugs like metoclopramide, sometimes with erythromycin for gastric emptying. Post-pyloric feeding may be considered for persistent gastroparesis. Patient positioning. Maintain bed angle at more than 30 degrees to reduce gastric aspirates risk. Intra-abdominal pressure, IAP, measure via installation of water into the bladder using a urinary catheter. High IAP is often neglected but correlates with mortality. The WSACS offers a 3-step management recommendation to reduce IAP. Therapeutic objectives for IAP management. Aim to evacuate intraluminal contents and lesions, improve abdominal wall compliance, and optimize fluid management and perfusion. IAP monitoring during enteral nutrition. Monitor to detect abnormal increases which indicate severe abdominal issues or fluid overload. High IAP, over 20 mm of mercury, may warrant pausing or reducing enteral nutrition. Use of laxatives. Sometimes used prophylactically to reduce defecation time, though their effectiveness is limited. Here is a practical guide on managing some common gastrointestinal problems in the ICU. Constipation. Frequent in the ICU with varying incidence. Defined as an absence of stool passage for over 4 days. Risk factors include dehydration, certain drugs, and immobility. Treatments include laxatives, enemas, and in severe cases, neostigmine. Prevention with laxatives can reduce other organ dysfunctions. Dietary fiber is crucial for prevention and gut health. Diarrhea. It poses nursing challenges and risks to patient skin integrity and nutrient absorption. Fiber-enriched enteral solutions can help prevent it. Antibiotics are a common cause, with significant associated mortality. Management includes rehydration and careful use of motility-reducing drugs. Probiotics and dietary fibers can help manage and prevent diarrhea. Short bowel syndrome, SBS. Nutritional therapy is vital for SBS patients to prevent dehydration and nutritional deficiencies. Management includes oral fluid restrictions, IV hydration, and motility and secretory drugs. Multidisciplinary care, including psychological support, is crucial. Artificial nutrition via enteral and parenteral routes covers nutritional deficits. Additional treatments might include cholestyramine for fat malabsorption and measures to prevent gallstones. Abnormal lymphatic drainage. Conditions like chylothorax and chylous ascites can lead to nutritional and metabolic issues. Management includes high-protein, low-fat diets with medium-chain triglycerides and sometimes total parenteral nutrition. Other treatments like therapeutic paracentesis and medications like somatostatin and octreotide may be considered. When to rest and when to feed. The decision on when to rest the gastrointestinal, GI, tract versus when to initiate or continue feeding in the ICU is based on the severity and nature of the GI dysfunction. Total stop of enteral feeding. Absolute contraindications include gut obstruction, perforation, and bowel ischemia. Parenteral nutrition is initiated until the issue resolves. Bowel necrosis. Bowel necrosis may develop unexpectedly in patients on jejunal feeding. Symptoms include nonspecific signs, severe shock, and multi-organ failure. Patients require prompt bowel resection and a period of bowel rest. Acute mesenteric ischemia, AMI, enteral nutrition must be halted during AMI and until the affected vessels are recanalized. Post-revascularization, enteral nutrition may have advantages over parenteral, including reduced infections and respiratory complications. Relative stop of enteral feeding. In cases of severe inflammatory bowel disease, bowel rest has been theorized to aid healing. For severe Crohn's disease, bowel rest is used to alleviate painful symptoms. In severe diarrhea, a combination of parenteral and enteral nutrition may be necessary. Chylous leaks necessitate the temporary cessation of enteral fats, using parenteral nutrition and MCTs. No restriction on feeding. Enhanced recovery after surgery, ERAs. Protocols minimize bowel rest, promoting early feeding. Early use of the GI tract for feeding is advised for intubated patients, with oral nutrition supplements as a complementary measure. Feeding strategy aiming at an early progressive introduction of enteral nutrition while monitoring feed delivery progression and considering the indication to parenteral nutrition or supplemental parenteral nutrition in presence of gastrointestinal dysfunction score. This strategy prevents both underfeeding and overfeeding. Hey there, awesome viewers. If you're enjoying the content and don't want to miss our upcoming videos, smash that subscribe button. And hey, don't forget to ring that bell icon to get notified. Let's make this journey amazing together. Proposed intravenous micronutrient complementation strategy combining 100 to 200 mg thiamine per day for 3 to 4 days and parenteral nutrition doses of vitamins and trace elements until enteral nutrition goals is reached, that is, for 5 to 6 days. In conclusion, the management of GI dysfunction in the ICU requires a vigilant approach that balances enteral and parenteral feeding, monitors for malnutrition, and addresses micronutrient deficiencies systematically. The choice between feeding routes should be guided by the patient's condition and the functioning of their GI tract. Thanks for watching and supporting us. You're the best. See you in the next video.